Welcome to Rad Onc Smart Review RadBio Edition. Prepping for those radiation biology boards, it's a big task, no doubt.
It really is, but understanding the fundamentals, especially the imaging tools we rely on every day, that's key.
Absolutely. And that effort you're putting in right now, it's definitely going to pay off, so stick with it.
Couldn't agree more. Today, we're going to focus on two real powerhouses in imaging for radiation oncology. That's computed tomography, CT, and positron emission tomography, PET scan.
Yeah, indispensable tools. Our goal here is to give you a really solid tutoring session, getting into the physics, the agents, and, how these actually apply in practice and for your board prep.
Think of it as a detailed walkthrough, really understanding how we get these images and what they tell us.
Okay, so let's start with CT. It's kind of the bedrock for anatomical imaging in Rad Onc, right? It gives us those detailed cross-sections.
Exactly. It's the backbone for planning. Without it, we wouldn't know where anything is in 3D space.
And the core physics, it's actually pretty elegant, isn't it? It all comes down to differential X-ray attenuation.
That's the heart of it. You've got an X-ray tube on one side, detectors on the other, and the whole thing spins around the patient. As those X-rays pass through different tissues, they block or attenuate the beam differently.
So like dense bone stops way more X-rays than, say, lung tissue, which is mostly air or fat.
Precisely. And the detectors measure exactly how many X-rays make it through from, hundreds, maybe even thousands of different angles as it rotates.
Right. And then the computer has to make sense of all those measurements, all that transmission data.
Yeah. It takes those readings, basically how much the beam was weakened along each path.
Yeah.
And uses some pretty clever math algorithms like filtered back projection.
To reconstruct that 2D slice, showing all the different tissue densities.
That's exactly it. And then you just stack those 2D slices up, computationally speaking, and bam, you've got your 3D patient model. Crucial for planning targets and sparing normal tissues.
Okay, so we get this map of densities. How do we actually quantify that? Put a number on it.
That's where Hounsfield's units come in, HU. It's a standardized scale, which is really important.
Standardized how?
Well, water is defined as exactly 0 HU. Air, which barely attenuates at all, is down around index of 1,000 HU.
Okay.
And something really dense, like cortical bone, can be plus 1,000 HU or even higher. So every little pixel on that CT image has an HU value tied to the tissue density there.
Got it. So those HU values help us identify tissues, and they're absolutely critical for dose calculations, especially when you're dealing with things like lung or bone where the density varies a lot.
Couldn't do modern radiotherapy planning without them. Now, sometimes the natural difference in density between tissues isn't quite enough to see what we need to see clearly.
Yeah, like trying to see blood vessels or specific organs well.
Exactly. And that's where CT contrast agents come into play.
These are substances we introduce to basically make certain areas show up brighter, right? By increasing the X-ray attenuation temporarily.
You got it. Their effectiveness really boils down to two things: having a high atomic number, or Z, and achieving a good concentration where you want to see things. High Z elements just interact much more strongly with X-rays.
Okay, so for the boards, what are the key high Z elements we absolutely need to know for CT contrast?
Number one, far and away the most common for IV injection, is iodine. Element I, high atomic number, it's water soluble, gets cleared by the kidneys.
Iodine. Check. What else?
For the GI tract, think barium, Ba. Usually given as barium sulfate, either swallowed or given rectally.
Barium for GI. Makes sense. And then there's one that can be a bit tricky because people usually think MRI.
Yes, gadolinium, G-Day. Primarily an MRI agent, absolutely, but because it also has a high atomic number, it does provide CT contrast. That's a classic board point.
Definitely remember that one. Gadolinium for CT too. Are there others?
Well, there are some other high Z elements that people are researching or using in specific contexts, often as nanoparticles. Things like gold Au, bismuth Bi, tungsten W.
But less common day to day.
Much less common currently. But their really high attenuation makes them interesting for potential future stuff.
Okay, so the core list is iodine, barium, gadolinium, and maybe be aware of gold, bismuth, tungsten. Need a way to remember those? How about, I brought gold before Wednesday.
Hey, that works. Iodine, barium, gadolinium, bismuth, tungsten, and gold's in there. Yeah, I brought gold before Wednesday. Not bad. Jot that one down.
Okay, good. Now, what about dynamic contrast enhanced CT? DCE CT. Is that something we need to know in detail?
So DCE CT is more of a functional CT technique. You inject the contrast, but then you image really fast over time. You capture the contrast arriving in the arteries, then moving into the veins, and then maybe a delayed phase.
So you're watching how the contrast moves through the tissue.
Exactly. It lets you measure things beyond just anatomy, like tissue perfusion, how much blood is flowing in blood volume, and even vascular permeability, like how leaky the blood vessels are.
Okay. So looking at the microvasculature function.
Right. In oncology, people use it to look at tumor vascularity, maybe try to tell tumor recurrence apart from scar tissue, or see if anti-angiogenic drugs are working.
But for boards.
Probably lower yield than the basics of CT physics and the main contrast agents. It's good to know what DCE CT is, but the detailed kinetics are less likely to be a primary focus for the RadBio boards compared to, say, PET scan principles.
Okay, good to know where to focus the energy. So CT gives us that amazing anatomical map. But like you said in Rad Onc Smart, we also need to understand the biology happening within that map.
And that is precisely where PET scan comes roaring in. It's a totally different approach.
Yeah, molecular imaging, giving us functional metabolic information that CT just can't.
Absolutely. It's become so central to managing cancer patients and planning radiation therapy effectively.
So how does PET scan actually work? How do you get an image from biological activity?
Okay, the core physics of PET scan is all about detecting radiation that comes from a special kind of radioactive tracer. This tracer has a positron-emitting radionuclide incorporated into it.
A positron emitter, so an isotope that kicks out positrons when it decays.
Exactly. We inject this tracer, it goes where the biology happens, like glucose metabolism or hypoxia, and then the unstable nucleus in that radioisotope decays. A proton inside flips into a neutron.
And out comes a positron.
Right. A positron, which is basically an anti-electron, positive charge, and also a neutrino, but we don't worry about the neutrino.
Got it. Tiny positive anti-electron. What happens to it?
It doesn't get very far. It travels maybe a few millimeters in the tissue, losing energy, and then inevitably it bumps into an electron.
Matter meets antimatter.
Annihilation. They completely destroy each other. Their mass gets converted entirely into energy. EMC squared.
Wow. Total conversion. What kind of energy?
It releases annihilation radiation, specifically 2 gamma-ray photons, each with exactly 511 kilo electron volts of energy. That 511 keV corresponds to the rest mass energy of an electron or a positron.
2 511 keV photons. Okay, and what's the really critical part for making an image out of this?
The absolute key is that these 2 511 keV photons fly off in almost perfectly opposite directions, 180 degrees apart.
180 degrees. That seems super specific. Why is that the key?
Because the PET scanner itself is basically a big ring of detectors surrounding the patient. And it's programmed to look for pairs of these 511 keV photons hitting detectors on opposite sides of the ring at almost precisely the same instant, within nanoseconds.
Coincidence detection.
That's the term. If 2 detectors directly opposite each other signal a 511 keV hit simultaneously, the scanner knows that the annihilation event must have happened somewhere along the straight line connecting those 2 detectors.
It doesn't know exactly where on the line, but it knows the line itself, the line of response.
Precisely. And then you collect millions, literally millions, of these coincidence events from all possible pairs of detectors around the ring from all angles.
And the computer puts all those lines together.
Yeah, using complex reconstruction algorithms again, it figures out where all those lines intersected most often and builds a 3D map showing where the tracer accumulated. Areas with lots of tracer, meaning lots of annihilations, show up as bright spots.
That's incredibly clever, taking advantage of that 180-degree emission. Okay, so what are the important PET scan isotopes we need to know, especially for boards?
The undisputed champion, the one you'll see constantly, is fluorine-18, 18F. Its half-life is about 110 minutes, which is really convenient.
Yeah, long enough to make it, ship it nearby, get it into the patient.
Right. It's used in the most common tracers, FDG, FMESO, FASA, FLT. We'll talk about those in a second.
Yeah, 18F is king. What else?
Then you have the short-lived ones that pretty much require you to have a cyclotron right there on site. Carbon-11, 11C has about a 20-minute half-life, used for things like 11C methionine or 11C choline.
20 minutes. Wow. Yeah, gotta be close.
Nitrogen-13, 13N is even shorter, around 10 minutes, used for 13N ammonia for blood flow sometimes.
10 minutes.
And then oxygen-15, 15O is ridiculously short, about 2 minutes. Used for 15O water, again for blood flow studies.
Yeah.
You literally need the cyclotron in the next room.
2 minutes. That's intense.
Yeah.
Any longer-lived ones?
There are a couple. Copper-64, 64Q, has a half-life of about 12.7 hours. Used in some hypoxia tracers like 64Q ATSM. It also emits beta particles, so it has some theranostic potential imaging and therapy.
Interesting.
And iodine 124, 124I. That one has a half-life of about 4.2 days. So it's useful if you want to do imaging over several days, watch something slowly accumulate or clear.
Okay, that's a good rundown of the isotopes. Now let's link them to the actual radiotracers and what they tell us biologically. The big one, using 18F, is FDG, right? Fluorodeoxyglucose.
Absolutely. 18F FDG is the workhorse of clinical PET scan, especially in oncology. What it measures is glucose metabolism.
And why is that so important in cancer?
Well, you remember the Warburg effect, right? Many cancer cells just gobble up glucose at a much higher rate than normal surrounding tissues. They're metabolically hyperactive.
Right, they rely heavily on glycolysis even when oxygen is around. So how does FDG tap into that?
FDG is basically a sneaky glucose molecule. It's a glucose analog. So those highly active cancer cells take it up using their regular glucose transporters, just like they would take up normal glucose.
Okay, gets inside the cell.
Then the enzyme Hicks kinase phosphorylates it, again, just like it would do to glucose. But here's the trick. FDG is deoxyglucose. It's missing a key hydroxyl group. So after that first phosphorylation step, it's stuck.
It can't go further down the glycolysis pathway.
Exactly. Gets metabolically trapped inside the cell. The more glucose the cell is trying to use, the more FDG gets pulled in and trapped.
So the brightness on the PET scan directly reflects how much glucose that cell or that tumor region is trying to metabolize. It's a metabolic snapshot.
That's a perfect way to put it. And that trapping is why FDG PET scan is so incredibly useful. We use it for initial tumor detection, for staging, finding lymph nodes or distant mets we didn't suspect.
And for defining our target volumes for radiation, right? Using the metabolic activity to help draw the GTV or CTV?
Precisely. It helps make sure we're treating the truly active disease, not just the anatomical blob on the CT. And it's huge for assessing treatment response.
How so?
You do a PET scan before treatment, get a baseline measure of uptake, the standardized uptake value, or SUV. Then you do another PET scan, and if you see a big drop in the SUV.
That suggests the treatment is working metabolically, even if the tumor hasn't shrunk much on CT yet.
Exactly. It can be a very early indicator of response or resistance.
Okay, FDG is huge. You also mentioned hypoxia imaging tracers. That sounds really relevant for radiobiology.
Oh, extremely relevant.
Yeah.
Hypoxia, low oxygen levels in parts of the tumor, is a major cause of radioresistance.
Yeah.
Hypoxic cells are just much harder to kill with radiation.
So we need a way to see where those resistant parts are.
Right, and that's what tracers like 18F-miso, fluoromesanidazole, and 18F-phazo, fluorazomycin arabinoside are designed for.
How do they work? How do they find the low oxygen spots?
They're both types of nitromenazole compounds. The key is how they're processed by cells depending on oxygen. In normally oxygenated tissue, they get metabolized and cleared out pretty quickly.
Okay.
But in a hypoxic environment, inside those low oxygen tumor cells, specific enzymes reduce these compounds. And this reduction process causes them to become reactive and bind irreversibly to intracellular molecules. They get trapped.
So unlike FDG, which gets trapped by metabolism, these get trapped specifically because of the lack of oxygen.
Exactly. High uptake of F-meso or FASA on a PET scan tells you this region is hypoxic and therefore likely to be radioresistant.
Wow, that's incredibly powerful information for planning treatment.
It really is, because if you know where the resistant parts of the tumor are, you could potentially target them more aggressively, maybe deliver a higher radiation dose just to those hypoxic subvolumes.
That's the idea of dose painting, right? Painting a higher dose onto the biologically resistant areas.
That's the concept. Instead of treating the whole tumor volume uniformly, you tailor the dose based on the underlying biology, like hypoxia.
I remember reading something comparing FDG and FASA, maybe in head and neck cancer, where FDG shows the overall tumor hotspot, but FASA can pinpoint the specific hypoxic-resistant core within that hotspot. It might have a better signal-to-noise for that specific feature.
That's a great example. It shows why having these different tracers is so valuable. FDG gives you the general metabolic picture, but F-meso or FISA can give you that critical layer of information about radioresistance.
Are there other PET tracers worth mentioning quickly?
Sure. Briefly, there's 18FFLT, fluorothymidine, which measures cell proliferation by tracking DNA synthesis.
Okay, proliferation.
Then you have amino acid tracers like 11-C-methionine, or a similar one called 18FFT. They're often used for brain tumors, looking at protein synthesis or amino acid transport, which can be high in gliomas.
Brain tumors, right.
And choline tracers using either 11C or 18F are common in prostate cancer imaging, related to increased cell membrane synthesis or turnover. Each one gives you a different piece of the biological puzzle.
So many ways to look at what the tumor is actually doing.
And of course, the way we use these clinically now, You almost never see a PET scan done alone. It's almost always a combined PET scan CT.
Yeah, those integrated scanners are standard. And that fusion is where the magic really happens for us in radiation oncology, isn't it?
Absolutely. You get the CT scan, which gives you that beautiful, sharp anatomical detail.
Your roadmap shows you the bones, the organs, the exact shapes and locations.
And then layered right on top of that, you get the PET scan information.
The functional data, where the glucose metabolism is high, or where the hypoxia is, or proliferation.
And because they're acquired together or fused perfectly, you can see exactly where that biological activity is located within the patient's anatomy. You know precisely which part of the tumor is hot on FDG, or where that hypoxic region sits relative to the spinal cord, for example.
It gives you the confidence to really define your targets accurately. It's the best of both worlds, anatomy and function together.
Couldn't have planned modern radiotherapy without it.
Okay, so let's tie this all together. Thinking about clinical decision-making, how has all this molecular imaging truly changed things in radiation oncology? What's the relevance for practice?
Oh, it's been completely transformative. I mean, fundamentally, the CT scan is the absolute foundation of our treatment planning process.
Can't plan without it.
Right. It gives us that 3D anatomical model. It's how we delineate everything, the GTV, CTV, PTV, all the organs at risk. And using CT contrast helps us see those boundaries even better.
That's the anatomical side. What about the PET scan impact?
PET scan, especially FDG PET scan CT, is now standard of care for staging so many cancers. It routinely finds metastatic disease, maybe in lymph nodes or distant organs that we just wouldn't have seen on CT alone.
And finding those mets can totally change the treatment plan, right? Maybe from curative intent to palliative?
Absolutely. It prevents heutolocal treatment sometimes. But even for curative cases, FDG helps refine the target volumes. That metabolic GTV often gives us a better idea of the true extent of active disease than just the CT abnormality.
So better target definition. And you mentioned response assessment too.
Yeah, tracking that SUV change on FDG PET scan during or after treatment gives us a really powerful early look at whether the therapy is working biologically.
And looking forward, those hypoxia PET scans, that potential for dose painting seems huge.
It really does. Being able to identify those radioresistant areas and specifically boost the dose there, that holds tremendous promise for improving local control, especially in tumors known to have significant hypoxia, like head and neck or cervix cancers.
It feels like we're really moving beyond just hitting the anatomical target towards hitting the biological target more intelligently.
That's exactly the direction. We're using imaging to understand the tumor's specific vulnerabilities and resistances and tailoring therapy accordingly. So mastering CT and PET scan, the physics, the agents, the applications, it's not just academic for the boards. It's about understanding the tools that let us provide better, more personalized cancer care. You're building skills you'll use every day.
Okay, fantastic. Let's crystallize some of this. Time for our clinical pearls, the absolute must-know takeaways for board review.
All right. Pearl number 1. For CT contrast agents, lock down iodine BioV, barium GI, and crucially, remember, gadolinium can also provide CT contrast, not just MRI contrast. High Z is the key.
Got it. Pearl number 2, the core physics of PET scan. Remember positron emission leading to annihilation with an electron, producing 2 511 keV photons flying off at 180 degrees, detected by coincidence. That's the sequence.
Perfect. Pearl number 3, 18F-FDG. No, it's a glucose analog trapped by hexokinase phosphorylation, measuring glucose metabolism. Think tumor detection, staging, metabolic volume definition for planning, and SUV changes for response assessment. It's the workhorse.
Excellent. And pearl number 4, hypoxia tracers like 18F-FMESO and 18F-FASA. They're nitroimidazoles trapped in low oxygen conditions. Their value is identifying radioresistant tumor regions, which opens the door for strategies like dose painting or using hypoxia-modifying drugs.
All right, feeling ready for a quick board blitz? Let's test ourselves.
Let's do it. Hit me.
Question 1. The primary physical principle underlying image formation in X-ray computed tomography, CT, is A, emission of positrons from radiotracers, B, detection of radiofrequency signals from hydrogen nuclei, C, differential X-ray attenuation by tissues, or D, reflection of ultrasound waves.
Okay, CT X-rays. How they get stopped differently. That sounds like C. Differential X-ray attenuation by tissues.
Exactly right. That's the fundamental basis of CT imaging.
Good start. Next.
Question 2. Which of the following elements is not commonly considered a strong X-ray absorber used as a basis for CT contrast agents? A, iodine, B, barium, C, gadolinium, D, hydrogen.
Okay, we just listed the main ones. Iodine, barium, gadolinium, they're all high Z. Hydrogen is element number 1, very low Z, so it's got to be dehydrogenase.
Correct again. Hydrogen has minimal X-ray attenuation, useless for contrast.
All right, keep them coming.
Question 3. The detection of two 511 kiloelectron pulse photons emitted in opposite directions is fundamental to which imaging modality? A, magnetic resonance imaging, MRI. B, single photon emission computed tomography, SPECT, CT. C, computed tomography, CT. D, positron emission tomography, PET, upbeat music plays.
Two 511 keV photons, 180 degrees apart, coincidence detection. That is the absolute signature of D, positron emission tomography, PET scan.
Nailed it. That's the core PET scan physics. One more.
Okay.
Question 4. A PET scan using 18F FDG is primarily assessing which biological process within a tumor. A, DNA synthesis rate. B, regional blood flows. C, cellular hypoxia. D, glucose metabolism.
18F-FDG, fluorodeoxyglucose, the glucose analog that gets trapped. It's measuring D, glucose metabolism.
Fantastic. That hits the key biological target for FDG. Solid run through.
You know, while standard CT and FDG PET scan are so routine now, it is exciting to think about where things are still evolving. Like you mentioned, DCE, CT for function, and really getting those hypoxia tracers into routine clinical use for things like dose painting.
Exactly. The promise is definitely there, even if the widespread clinical implementation for complex strategies like dose painting is still developing. There are technical challenges, validation needed, but that's the frontier.
It really feels like the goal is moving towards biologically conformal radiotherapy, not just anatomically conformal, using these images to guide not just where we treat, but how we treat different parts of the tumor.
That's a great way to put it. Integrating all this functional and metabolic insight right into the treatment plan, it's a continuous process, and understanding these tools is how you participate in that future.
All right, let's wrap up this session with a quick summary of the key points.
Okay. We started with CT anatomical imaging based on differential X-ray attenuation. Remember, Hounsfield units quantify density, and contrast agents like iodine, barium, and gadolinium enhance visibility.
Then we dove into PET scan, functional imaging using positron emitters, key physics, positron emission, annihilation, two 511 keV photons at 180 degrees, coincidence detection, common isotopes, 18F, but also shorter-lived ones like 11C, 13N, requiring local cyclotrons.
We highlighted the major tracers. 18F-FDG, the glucose analog for metabolism, staging, response, planning volume, and hypoxia tracers like 18FF-MISO and 18F-phasa, identifying radioresistant regions.
And critically, the power of combined PET scan CT, fusing that anatomical roadmap from CT with the functional landscape from PET scan for precise localization. This is essential for modern radiation oncology planning.
Absolutely. These tools are fundamental for diagnosis, staging, planning, response assessment, and they're pushing us towards more biologically driven personalized treatments.
So keep reviewing, keep practicing those questions. You are building a really strong foundation. You can definitely handle this on the boards.
And remember, you can find more resources, including practice oral boards, over at radoncSmartLearn.com.
Definitely check that out. And make sure you subscribe to Rad Onc Smart Review so you don't miss our next session. Thanks so much for tuning in.